I heard this story that apparently at the comedy club, Robin Williams would turn up sometimes, and he would do a set, and afterwards no one else would go on, because he was so good. Mark Caulfield is now going to follow Rod Flower. I think if John Vane set us up, and obviously Rod and Eric were there in the middle years, it's definitely Mark who has taken us to where we are now, the size and scope of the William Harvey. And that comes down to his incredible energy, his application for every grant that goes, his networking, his indefatigable, is that the right word? Energy to build the William Harvey and to bring everything here that we have today. So, over to Mark.
Thank you. So, I will be as brief as possible, but I want to thank everybody for coming today and tomorrow. I hope to see you all here again tomorrow. It's been a privilege to be involved with Maro and Amrita and also Adrian Clark over the years in working in this organisation. And I'll take you through some thoughts of how it's evolved at its 30th birthday. And in fact, actually, it's not too long ago since the 10th anniversary where you erected a football screen to watch the football, I remember, outside the marquee because it was a Euro game. I think it was England versus Germany or something, which inevitably we would always lose. Of course, the name of this institute comes from William Harvey, who worked here around 400 years ago, and he gave us our modern view of the circulation. And there's quite a lot of resemblance, Daphne, to him and John, because actually there's John receiving his Nobel Prize from the King of Sweden. And William Harvey actually was a person who believed also in serendipity and serendipitous discovery. And I'll show you an example of that in a moment, which I found by chance. This is Bart's Hospital. And the reason that I'm showing you this is that this is one of our two hospitals where we have just completed a major rebuilding program of 1.3 billion. So this is a new £400 million cancer and cardiovascular and endocrine centre where we're serving a community now of 6.3 million. And as you'll see as we discuss this and focus in on aspects of our hospitals, what we've done is evolve the Institute into being cheek by jowl with the hospitals and patients and communities that it serves. So I wanted to show you this to show you that, like John Vane, William Harvey was very much a lateral thinker. You won't be able to read any of this, but I had to do a talk about William Harvey. And this is from the minutes of the governors of St Bartholomew's Hospital from 23rd of March, 1639. Anyone from America? Hey, look at this date. Steve, Bob. So this day it's ordered and agreed upon that a scurvy grass drink will be prepared with the help of the apothecary under the direction of Dr. Harvey. That was William Harvey. And actually, the ingredients of this drink, you won't be able to read any of this because it's written in Old English, but they contain multiple items that are things that include vitamin C. So this is over 61 years before James Lind conducted a trial of vitamin C to prevent scurvy at sea, and William Harvey wrote this in the minutes of Bart's Hospital. The slightly worrying aspect of this recipe is this is Old English, so if you can't understand it, that's perfectly fine. None of the rest of us can either, and some of us are actually from Britain. 8 gallons of beer, this is. So I wonder if the people, I bet the scurvy was cured, but perhaps they got something else. So John, of course, was somebody who was an ultimate lateral thinker. And there's Bengt sitting next to him at the Nobel Awards ceremony. But I just looked at this today because I'd not seen this photograph with the guy here in it. What happened? Didn't he get the dress code on his invite? What do you think went wrong? Or did he win extra Nobel Prizes? I'll be asking you later, Daphne, but he certainly stands out. But what John did that's not well known is John also inspired the creation of ACE inhibitors. And Rod told me this story, that in the production of ACE inhibitors, because he worked on these drugs, and they're amongst the most widely used medicines to treat heart disease in the world now, he is not credited with this really at all, but he actually inspired Squibb to make the first ACE inhibitor. And before they made a medicine that you could swallow and be absorbed, they made a protein that you had to inject. It was called teprotide. And there's a letter which Rod has told me about that was in John's archives from Chuck Smith at Squibb Pharmaceuticals, which said, "Dear Dr. Vane, the board of Squibb Pharmaceuticals are extremely concerned about the amount of money we've had to spend on teprotide. We've now spent $20,000. Not long afterwards, Cushman and Ondetti created the molecule that was captopril, and it was the first billion-dollar drug worldwide. So this is not widely known, but this is an example of what our founder did in terms of not just the areas that you know about him, but in lateral thought. So in 1986, he decided to invite some friends to come and have fun. And literally, as Daphne says in her contribution to the brochure, that's the way he thought about it. And he assembled this group of characters, and it's a pleasure to welcome back Eric. Of course, Rod has just spoken. Ian and Derek are sadly no longer with us, and Gus couldn't be here today, but he sent you all his best. In fact, Gus gave the John Vane lecture in the 20th anniversary. And Gus gets quite worried about things, and he's on the phone to you quite often. So pretty much every Sunday for about 6 months, he would ring me up and he'd say, "Hello, Mark, it's Gus here. I'm ringing you to tell you that I'm very worried about this lecture you've asked me to do. You've asked me to talk about my life in science. Absolutely nobody's going to be interested in my life in science. There's no interest whatsoever for that. Can I please talk about my platelet aggregometer?" I said, "Well, you can have a bit on that, but you must talk about your life." So about a day before he was due to give the lecture, just as we were about to start the thing, he phoned up and said, "Hello, Mark, you know this lecture you've asked me to give?" And I thought, oh no, he's going to say I'm not coming to do it. He said, "Actually, I've discovered my life's quite interesting, really." And you who were there know the rest. So this is an illustration of the early way the Institute worked in partnership with industry and funded often by unrestricted grants. And this is a meeting with Ono, and you've seen this photo from Rod. And I show you this because this is, I think, at the heart of the future as well as the past. For a while, this became not the way to work with industry, but there is now a resurgence in the era when many medicines fail in later phase development to have closer partnerships, which we're committed to here at the Institute. But I show this particularly because I remember Rod telling me, as he's my mentor, he said there was one meeting with Ono where eventually John couldn't work out why they were actually funding the Institute. And so he said to them, he said, what are you actually getting out of this? And there was one of those pauses, and everyone sort of looked at their feet a bit. And eventually the guy in charge said, "We want to know how you think." And that was it. That was it. That's what they wanted. Pardon? $5 million. $5 million to know how he thought. So, but the actual thing was there were lots of fruitful partnerships out of that in inflammation science, and many friends who continue, but because they trained here as part of the Ono partnership, to be part of the family. Indeed, we've trained over 360 PhD students, distributed most of whom are still in science around the world since the inception of the Institute. So this is a 30-year journey, and this has changed. It is now very different to the original model. Here are the team that has surrounded John in the early days, and I think Tim will have convinced you, and if Tim hasn't, Rod will. They had a lot of fun. And if I find anyone drinking beer in the labs, there'll be trouble. So, this is bad influence you are. But the important thing was that Rod recognised the benefit of coming closer to the hospital, and so he brought clinical pharmacology, myself, and then Ben Benjamin, who also directed the Institute for a while, across to join in. And that began the process to bring the hospital and the lab cheek by jowl, right next to each other. And that's something we've particularly developed since that time with the union with endocrinology in 2002. The model of funding the Institute with unrestricted grants really came to an end in the late 90s, and so the Institute that had been independent merged with Queen Mary and has been part of Queen Mary, who have significantly invested in the Institute in that time, entirely refurbishing this building, also bringing new other Institute partners like the Bart's Cancer Institute into the fray. And so we expanded, and new people joined us: Cos Pitsalis in experimental medicine and rheumatology, Ken Suzuki in stem cells, and Suzanne Norshag, who brought her microvascular to the Institute. And then we opened and raised money for a 25 million heart centre, which you're welcome to go and see this evening. I'm happy to take you to see it during the reception if you want to, which we opened in 2011. And we were joined also by Adrian Hobbs, Federica Morelli-Berg, Andy Tinker, and Panos DeLucas. And each of these people are international star researchers. But the thing that I wanted to emphasise to you is this growth trajectory here. Now, it isn't always the case that size is better. So in other words, bigger is not always better. But not only have we actually grown, and today there are 410 people in the Institute. So you can see that in the last 2 years we've grown by 60 people. And as you'll see in a minute, we're appointing more at the present time. Such that, let's measure the excellence though. In 2008, when we did this dreaded research excellence thing that Rod was mentioning, 65% were either world leading or internationally excellent. But by 2014, 46 people, and these are our senior faculty, were 90% of whom were world leading or internationally excellent. And that actually is the overwhelming majority, 72% of the eligible faculty in the Institute who were able to be returned. So how are we going to be working, building on that platform and moving forward? Well, if you imagine that the phase between 86 and 96 was establishing the platform, establishing the excellence of the Institute, and then the period between 96 and 2006 was building the case for bench to bedside. So all too often, we would talk about things, particularly with people, say, for example, like Yuti Chandrosky working on developing a gene therapy, and he'd say, I've got it working in this model, and I can show it's of benefit. I'm now going to try this other virus. But nobody ever brought it into the humans. And so what we've tried to do is create the philosophy where the basic scientists are totally connected to the clinicians, treated equally, and therefore actually delivering a translational mission which will benefit patients. And now we're moving, therefore, into the next phase of our existence, which is improving outcomes and prevention. Because actually the future of healthcare is about stopping people getting disease. It's otherwise unaffordable and unsustainable in a Western society. And so what we have to do is more preventative strategies and get better at preventing disease. So let's look at some of the things that we're doing very briefly. And this is the donor wall of the William Harvey Heart Centre next door, recording the life of William Harvey. So we now have, for these 410 researchers, they work in different aspects, and they wouldn't all say they're doing every aspect of this because some of them are not. But imagine if you could take discoveries in genomics, in measuring other body substances in body fluids, proteins, metabolic signatures, and you could integrate that to discover new medicines. And then you could use the strength of this institute in its totality to bring that into study in human laboratory with cells from humans, recalling patients by their genetic makeup to study, taking biopsies of their skin, as we do here now at the Institute, getting the skin to reverse to a more primitive cell type, and then making it differentiate down a line that creates a heart cell that beats in a Petri dish. So a disease in a dish, if you like, that you can expose medicines to, test things, and do it in the tissues from people that will receive these medicines. In other words, using the platform of our own experimental models that we use traditionally, but actually also adding depth and value with a human laboratory. And we don't do medicinal chemistry, but we can connect to people who do, so we don't need to do that. But the other thing we have built, and you'll see this embodied in a moment, is we built the capability to take our work into community, and we can reach now 6 million people densely packed into North and East London. And so if you imagine our three strands of research, disease-oriented and inflammation, cardiovascular and endocrinology, and that now it's the moment to deploy genomics in healthcare, to stratify treatment, to choose treatment so we try and get the right medicine to the right patient at the first point, and we understand the implication of that medicine for that patient in terms of side effects. To use our platforms for experimental medicine in patients and in the laboratory to deeply characterize patients so we can segment disease. Eventually, some of the common diseases that we lump together today, possibly coronary disease, maybe blood pressure, will become rarer sub-segmented diseases as we get closer to the biology that defines them. And our institute and university want to be positioned to develop the medicines that will face those patients when those diseases are subsegmented. And then to use the fantastic platform of pharmacology and the largest pharmacological institute in Britain, one of the largest in Europe, and to take those therapies into patients, connecting the basic scientist into clinical trials in a way we would not have done 15, 20 years ago. So we will be the premier centre for doing this, and we're well advanced on that, as I hope I shall persuade you. And we'll be doing this in the area of bringing new molecules and also now increasingly devices into patients. That will be a mixture of new targets, but actually, as Chris showed you very elegantly earlier, it might be about taking a medicine that's used for another purpose, or even bringing a medicine off a shelf in a pharmaceutical company to bring it into patients so that they can get benefits. Something that we've abandoned working on for a disease because it didn't work, but maybe we can make it useful for something else. New approaches that are dietary. Our International Scientific Advisory Board, who are here with us today, particularly advised us at our last meeting with them to consider this work, and that's embodied in something I'll show you in a moment. But what we're now in the process of doing is connecting that through our Medical Research Council Centre that we've won here jointly with University College London and the London School, which is called the FAR Institute. And what that is an Institute of Electronic Health. It's about placing electronic health data locked normally in healthcare systems and not available to the researcher around every study that we do. So imagine that although you may study a small number of patients with a medicine in an early phase trial, what if you could follow those people longitudinally using the electronic health record? What if you could enrich that data further? What if you could use the technology that's sitting in your pockets now, or possibly on your tables in front of you, to communicate remotely with patients, to remotely sense the disease changes? What if you could use that to choose whether or not that patient returns to the clinic? Or if their disease activity is not active, maybe they don't need to come to their appointment. Maybe they can come another time when their disease is active. This is probably the future. And actually, the reality is that patients are embracing this. Apple, for the iPhone, developed ResearchKit. ResearchKit is just an app on the phone. Within 1 month, 35,000 people had enrolled in a heart disease study at Stanford. Now, there's no amount of money that could afford a team of humans to enroll those patients. They did it on an app on an iPhone. And they did it because people see this as the future. So if we, as the community that serve those people, don't embrace these technologies, they'll do it without us. And actually, what we need to do is to make sure that we do it with them so that we get the most valuable data for the future of their healthcare. So we've now enlarged to 72 faculty. We've got 112 PhD students. And I show you only these numbers, but simply to show you the scale of the institute and its reach. A very important feature is that 40% of our income is from teaching and 60% from research. Now, we've welcomed new people this year, and if you like, an index of vibrancy is whether you can persuade other people who are international star researchers doing cutting-edge research to come and enrich your faculty and add depth and critical mass. So the first of those has arrived, Maurice Brown, and we're delighted to welcome him from Cambridge. And he has brought expertise in stratifying adrenal hypertension, and he's a world leader in that field. We have also, in partnership with Yale, because we now have a partnership with Yale, and actually one of our alumni, Bill, is here. I can't see you, Bill. Oh, there you are. Hi, Bill. So Bill Sesser from Yale, he's now working at Pfizer, but we have a burgeoning partnership in genomics and devices with Yale, and we've just made an appointment of Alexandra Lansky, 50% between here and Yale, to develop a device innovation center with this man, Andreas Baumbach, and Anthony Mather over at the Barts Heart Center. And to give you an idea of the strength and caliber now of the team between the hospital and the William Harvey, we've just recruited the entire extracorporeal membrane oxygenation team from the Royal Brompton Hospital. So that's 9 senior members who have joined us and brought that skill, which means that we can start to explore the use of mechanical devices in heart failure in patients who have end-stage heart failure who won't get a transplant because there aren't enough organs. We've got new chairs coming. There are 8 more chairs to be appointed in this year at the Institute. So I imagine by the time we speak next year, I will be telling you, or somebody will be telling you, about 500 people being part of this Institute. I'm very proud of this, which you're welcome to come and look at, but don't touch it because it's glass. This is putting UK pharmacology on the map. one of our key relationships is with the British Pharmacological Society, and we were delighted to be given this award, which is in recognition of outstanding contribution to the discovery and developments of medicines. And Amrita and Maro collected the award, and you'll hear more about it tomorrow. But this is a signal of the external recognition that we're receiving for the work we're doing. I'll just focus on some general things now, and then tomorrow we'll give you some more detail. Maro will give you some more detail. So we've got a population in North and East London that's 6 million in scale, and so what we spent 5 years doing is uniting our university with UCL in terms of a partnership, and we've just completed last year bringing University College London Heart Hospital to Barts. So we brought 3 hospitals into one, and what that means is we've now got the largest heart hospital in the country and one of the largest in Europe. We're providing 80,000 patient episodes for care all the way out across North and East London. What that does is it provides you with a scale. And when you have scale, you can identify subgroups within scale that allow you to get closer to the biology that causes disease. And when you've got scale and you've got what is small sections of disease, but you've got reasonable numbers, you can do the trials others can't. So that's the virtue of scale. Now, it doesn't matter whether this is cardiovascular disease, but I can tell you, Cos will tell you, he's got 35,000 patient episodes per year in rheumatological disorders. We've got a similar number in endocrine disorders. So this is now a very big centre for clinical care, and we pushed our science right up against the hospital. So we are creating the research hospital with the community that will allow us to find people with disease that we need to investigate. So we've allied our strategy now with UCL, although we continue to operate independently as the William Harvey Research Institute around some key strengths in high blood pressure and pharmacology, disorders of heart rhythm, stem cells and organ protection, and advanced imaging, where we've got some of the latest advanced imaging in this building. And just before I leave this picture, we have a burgeoning plan with others to develop this centre here called the Robin Brooks Centre, or parts of it, as a device innovation centre. So I want to show you how we've integrated ourselves in terms of our science. So this is some work that Amrita's done, and I picked this because some of the spur to this is our knowledge of how the body works and the pharmacology. But this is a system that had been really abandoned for targeting in blood pressure largely. And what Amrita did with partial support from my own and Patricia Monroe's work on genetics, showing that this pathway was very important in driving blood pressure in people with high blood pressure, is she showed that if you swallow beetroot juice, some of it comes out in your urine, but the nitrate in it goes up, it's concentrated in the saliva, gets made into nitrite by bacteria that live on the back of your tongue, and then it's absorbed again through the stomach, and it becomes nitric oxide. And this lowers blood pressure as effectively as a standard blood pressure lowering medicine. Now, why I've included this, because a number of you have seen this before, and this is Amrita and Vic's work here, shown here, and they've now gone on to prove this in a randomized controlled trial, is because before this first paper in 2008, there was a very low-level beetroot market worldwide, and now latest data which has been gathered suggests that's now $370 million US. And that's crop growing, it's making of juice, it's making of various other things. This isn't healthcare led, it's not led by us. It's led by it is led by the publications that were made from here and driven partly by that, but it's also driven by other work by other people that shows that this particular form of nitrate allows you to unload oxygen, and so athletes take it. But actually, the people have done this themselves. They've made this decision. And so this is part of the future of embracing patient choice, and they will choose it with or without us, so we must make sure we're engaged. So we've benefited greatly, and I'm very grateful to the Barts charity, and Amrita has been pivotal in this with Charles Knight at the hospital. We've just won 10.2 million last year, and the appointments that you saw earlier are being made out of this in the areas of rare disease, devices, hypertension, heart failure. And we're also integrating what's called patient-reported outcomes, which is using your smartphone and having apps on them for the patients to communicate directly with you about their condition, so that you can adjust medicine in real time, make changes, and develop a platform. Now, as part of this, you have to find the patients. So about 7 or 8 years ago, we started a project to integrate, and it won't surprise you, those who've been connected to healthcare, that the NHS rarely has one system for managing something. And so we integrated 7 different systems that manage different aspects of patient care into one single database, identifiable. And so what we've done is we've got patients now have agreed and are really supportive of generically consenting to participate in research. And so we've taken those identifiable data sets and we remove the identifiers, but we keep them connected to the original patient record, and we push it across into the university, and researchers here will be able shortly to ask of those data, have you got any people with this? And every year we can recall those patients 4 times a year to participate in research if they wish to do so. And this is an example of how you can use the scale of this practice to engage people in research. And very large numbers of the patients of the hospital are signing up to this now. They're very enthusiastic about it. What we're next going to do is link this to all their healthcare records. So their records in the family physician or primary care, records in the hospital, and their outcomes. So you create a longitudinal life course resource, which means any time you do a study here, you'll be able to enrich it if the patients have consented with longitudinal data. And this adds value and depth that runs beyond the trial and is use of real-world data. So an initiative led by Marrow, and this is a fantastic initiative, which has got great support from Arthritis Research UK, is to take the genomics and stratified medicine concept, combine that with our strength in vascular inflammation and cell trafficking, and use that to identify new targets, and also incorporate regenerative medicine into that to address inflammation and inflammatory diseases. And this is the Centre for Inflammation and Therapeutic Innovation, and Marrow's going to say a lot more about that tomorrow, so I won't say any more. I will say a little bit about stratified medicine. This is an example of Cos Pitsalis' work, which some of you have seen before, but you can use biopsy taken for a small joint here in patients with rheumatoid arthritis. You can just take a piece of the lining of the joint, and by doing certain tests on it, you can work out what changes are occurring in the lining in response to the disease. And if you shine a Doppler probe on it, you can see which areas of the synovium, the lining of the joint, are active, and you can biopsy those and then use this. And there's some evidence to suggest, and Cos is now leading the definitive trials across the whole of rheumatoid arthritis, that this can be used to choose the right biologic for the right patient first time. And that's what we're doing here. So in endocrinology, we also have a new strategy, and actually there's been huge success there, particularly in rare diseases, disorders of growth, and the pituitary adrenal axis, which are important organs that control us on our everyday lives. And for example, researchers there have unraveled many causes of rare disease, including certain tumours that affect the pituitary gland, that cause gross disfigurement in patients, particularly difficult for women to bear, and these can now be identified early and early intervention considered. And this strategy means that the endocrine centre, which is already very well linked into the hospital, and actually is one of the sections that has life course linkage, so it has paediatric endocrine care, and it also has adult endocrine care. And we're very grateful, I promised I wouldn't mention you, but I lied, Chris, to Chris Hobden for helping us to make sure that we had a strong paediatric endocrine academic offering linked into a fantastic clinical service. So with Steve DeCherney, who's here today some years ago, with Dennis Gillings, who owned Quintiles at that time, we invented a concept called a concentrated trial hub, where we concentrate clinical trials in one location. And it doesn't matter what therapeutic area, it doesn't matter what aspect of disease. What we did was to create a partnership where the trials will be concentrated and there will be a hub that manage those trials. This is called a prime site. And we've enrolled across North and East London, University College London Partners, which is the health system in this part of London. We've enrolled, working with teams across North and East London, 3,359 patients in trials opportunities they wouldn't have got to participate in. And many of those are in areas we focus on, but a lot are also in cancer. And this has led Quintiles to duplicate this 24 times in other parts of the world. And we've just done some health economics on it with Quintiles, and we can show that there's a £24 million healthcare gain through this initiative to the United Kingdom health economy. That is defrayed healthcare costs, new drugs brought to patients that they would not have received for some years in the healthcare system, and the cost of doing the trial, which means the patients get the care and the NHS can deploy its money elsewhere. So we also have another partner, and that is through me, and this is Genomics England, where we are sequencing 100,000 whole genome sequences in patients with rare disease, cancer, and pathogens. We're going to have a talk about it tomorrow, so I'm not going to say too much, except to say we're returning diagnosis to the National Health Service now, and we've built a legacy of infrastructure. So there are 13 genomic medicine centres in England, and Scotland, Northern Ireland, Wales. It's taken me 3 years, but they're nearly joined in now. Boy, that was hard work. Anyway, another story for another time. But we've also got inward investment coming into the UK from key partners like Illumina, who invested 60 million in a new European headquarters in Cambridge. And this is our sequencing centre, which was built and finished in December, and in January it opened, and we're now sequencing. We've sequenced 10,000 genomes. So I want to tell you about this family here, and you'll hear about other families tomorrow, because this is an example of what we want to do working with our foundation, our charity, William Harvey Research Foundation. And this is focused somewhat on rare diseases, because this is very individual impact. So this dad and mum, the double lines mean they're closely related. And they had a child who perished at 4 months, and he never left the ITU. He had severe recurrent infections, he had neurological disorders, and he never recovered, and they didn't find a cause in his life. And his parents enrolled him with our agreement in the program after his death, because they wanted to know what the likelihood of them having another child like this would be. And so we enrolled the family, and then mum got pregnant, and she said she did not want any testing and she didn't want to know any results. But at the 8th month of pregnancy, she became very anxious about what might happen. And as it turns out, that's proven to be fortunate, because actually we then looked at the gene panels that face diseases that might have caused immunodeficiency and severe inflammation. And we found a mutation that affects vitamin B12 transport inside cells. So you can absorb vitamin B12, a vitamin that you and I eat every day, in your gut, but you can't get it inside the right cells. But the good news is, if you give extremely high dose of vitamin B12 because of other pathways and just seepage into cells, you can get round this. So there are instances where abnormalities such as this child had have been avoided. So this child was born in February. I'm sorry to tell you this child was also affected, but had extremely high vitamin B12 from birth. And so far, it's not clear yet, but so far is doing much better than their older child. And that's the power of whole genome sequencing in individual cases. So this is very different from the medicine we often think about, which is about populations and groups of people. It's very much at an individual level. So our foundation, who've supported us valiantly over many, many years and have been key to this institute's success, have come up with some elements of fundraising focused particularly on the John Vane Chair, which we particularly targeted, but also on seeding funding to get early stage concepts that are not readily fundable by others off the ground. And I'm very grateful to the team at the foundation, particularly Lisbeth, John Gordon, Michael Draper, Peter Marshall, Steve DeCherney, Bob Naismith, and Tim Williams. Sorry, Tim, I forgot to put your name on, I apologise. So the important thing is what these guys have done, and you can see the brochures in the marquee, is they've come up with a plan to support us in the areas where they think they can really make a difference. And we absolutely support them, and they're doing a fantastic job. So the final thing is we've synthesised all I've told you about, working together with a team across the Institute here, into an application for £24 million, for which we'll be interviewed in a few weeks' time, for a new biomedical research centre. This is funded by our National Institute for Health Research. And there are 4 themes in this that come from the William Harvey. 3 cardiovascular themes, 1 musculoskeletal theme, and we're working with our colleagues in other parts of the school on digestive disease and oral health. We can fundraise here. We raised over 25 million for this building here from various charities. I'm very grateful for Sarah Levine from the Charles Wolfson Charitable Trust joining us today, because they endowed the laboratory which supports Andrew Tinker and Adrian Hobbs, and also to others, the Wolfson Foundation, Quintiles, and the Barts Charity. We love public engagement here. Fulvio's in charge of it, but we've also got fantastic people doing that work, Jane Batchelor and others. And we have an annual science festival, but this is something we did a couple of years back at the Royal Society, and it's an example of how we want to connect to the future scientists to make sure the replacements for us, when we feel like we want to do something else, not teaching English, of course, would be the next thing to do. But as you will have gained the impression now, we've moved to having a really world-class faculty and to become a centre for international excellence in pharmacology and therapeutic innovation. We're now moving to device innovation in addition to medicines, because a combination of medicine and devices may be the future for many diseases, and particularly using electronic health and remote sensing. So our teams here at the William Harvey and across Queen Mary can remain at the forefront of bringing opportunities to the 6 million people we serve. And what we need from colleagues elsewhere is targeted funds to achieve these goals. It's been a great pleasure to have you here today. I want to thank each and every one of you personally for coming. I want to thank all of our speakers, our alumni, some of whom have travelled a great distance to be with us. There's more to celebrate tomorrow, and many of you who attend that will come in direct contact with our scientific teams. But I feel I've now kept you long enough. All I want to do finally is to thank the team that pulled this together, and we'll thank them properly tomorrow evening. But Sabrina, Paul and the committee that pulled it together, you've done a great job. I think we can be very proud of it. And I'd like to thank Maro and Amrita and all of you for putting up with me. Thank you all very much.